do you think about this question? Like, someone who is depressed and I think the treatment is not working and asking about what to do next. Do you think, like, just the antidepressants failed and we just have to go to ECT? What did you decided last time?
I think we can increase the duration of antidepressant.
Okay, duration
See
of.
if it is work.
Okay, like, that's a nice answer, like more believable answer, I believe. Let me see. Ideas. Okay, he's also sharing ideas. Just I read this section well, a little bit controversial. One thing that is important, that when it comes in terms of antidepressant, it's not like, my drug is not working, I'll suddenly change the drug. Always you have that option of increasing the dose. Okay, and if side effects and other things are there, in that case you will reduce the dose or change the dose. But since your drug is not working, there is a word, like, this is the reference website, up to date. You can take a picture of this one, and in this one there was written that you should at least use 2 trial of antidepressant, and when you will also go through antidepressant, there is a provision, like, you can increase the dose. Even in case of antipsychotic antidepressant, you can also reduce the dose first when the side effects are coming. And even here, it's not working, like, it's not even the side effects, so it's not working. Of course you can increase the dose, so the same one actually you can increase. Okay, this question can also be asked in another way. We are really not sure, like, the what was going on in the recaller's mind. Was it the actually treatment failure case? Treatment failure case is means, like, antidepressants is given couple of times. Okay, if it's like that, I know we'll start from here, right? Like, 2 trial of, say, antidepressants are done. So now what in that case? Then we'll count it as, like, resistant case of depression. Normally these instructions are given very clear cut in the main exam. Since it's a recall, things are not clear. So what do you think now, what to do? So not working and thinking as like a resistant case, yes, we can add another drug. Is it possible? Like, initially we saw the venlafaxine and some drug. So can you use MAO with SSRI or these things? What do you think? Any antidepressant drug, SSRI and MAO, can you use them together normally? No.
There will be this problem of
Yeah,
serotonin
yeah,
syndrome.
there will be certain syndrome, and with MAO there is another one. There is the hypertensive crisis. So we have to be careful, actually. So we have to choose a intermediate one in that case. These things I'm talking only when the initial 2 trials are failed. In our case, if we just go and see this question again, in this one, since it's a recall and the recaller, he didn't mention that one clearly, that is it the first time he's taking the drug, or is the all the treatment thing is failed, actually. So if we think, like, it's a major depression and your drug is not working, I like to go with B, actually, like increase the dose of the venlafaxine rather than directly going into ECT. Okay, so I would like to go with the B here. So 2 trial of antidepressant. So we'll come with a flowchart. If it's not working, we'll count this as resistant case. Then you can consider adding another drug. Okay. Any ideas about dosing of that drug? Anyone? How to use the the dosing thing? Say if I want to increase, if I want to add another drug, what will be the other drug's dose? Will it be remain the same, or should we reduce it? Like, what do you think? Like SSRI, and we add SNRI along with it. Dr. Shovik, any idea?
No,
Okay.
I was thinking of maintaining it for 6 weeks and then we'll titrate it to another one, or
Yeah,
maybe the
now,
same thing.
yeah, that's correct. Like, we have to maintain that one 6 weeks. If I'm saying if treatment is failed, and when treatment is failed, and now you are feeling like you should add another one, like, like 2 trials are failed. Initially you also increase the dose, and everything is failed. So now what? So ECT is the last resort, actually, isn't it?
should start with lower dose.
Yeah.
Then
Okay. Then.
3 weeks, after 3 weeks, we will gradually increase the doses, like after looking at the response. Like if the medications looks like, we will go through the depression questions and anxiety questions.
Okay.
So if we see the score is lower than previous, or is a little bit improved, because most of the time the severe score is like 18 or 19.
Not bad actually. No, correct. So thing is, if we're starting from if it's a resistant case or something like that, or in any case, true trial of the same depression is failed, and you are feeling like you should add another one, there is a provision you can add another one. So according to up to that, they add that one. Like if it's a treatment failure case on a resistant case, in those cases actually, if you are increasing one drug dose, and if you are adding another one, you should reduce the another drug's dose. Or if you are adding another drug's dose, like it's like a normal one, you should reduce the previous drug dose. Like if you are using the two antidepressant drugs in similar dose, there would be some contradiction. Okay, so sometimes you need to make a balance actually in this one. So this type of option you might see in the question actually. So if I add one, the other drugs dose should be reduced actually, otherwise there would be side effects. Okay. Okay.
So, Dr. Shahriar,
Yeah. Yes, doctor.
in this case, if we will first increase the dose, and then if it doesn't, if it again doesn't work, then we will add another drug, yeah? The second.
Initially trial of antidepressants, according to up to date, two trial of antidepressant, it could be the same drug. If you feel like it's a big field, sometime you need to add another one. Those are chronic patients, sometime you need to add another one. But say the venlafaxine, the dose you are using now, you can't use the similar dose. If you're trying to use mitrazepine along with the venlafaxine, in that case you need to reduce little bit the dose of the venlafaxine and then add the mitrazepine actually, otherwise there would be the side effects of the antidepressants. Okay, so only that one I was trying to say. But initially, like when we are using the venlafaxine, we can first of all increase the dose of the venlafaxine. Okay, that's we have actually. So two trial, like two times you tried with that similar drugs, that has to be there initially, then you can do some other thing else. And the ECT is said like it is the last resort in most cases. Okay, it is written like that.
Oh, thank you.
Okay, so there's the similar thing. You can take a snap of this one, how to start another antidepressant. So treatment resistant patient, like it's a resistant case where treated like do not response. First criteria has to be made that it has to be like a 6 week of a certain week of the target dose, and now it's not going well. We suggest tapering or discontinuing the failed medication over 1 or 2 weeks at the same time that another adjuvant medication is started and tapered. Why you should do that in 1-2 weeks? Because there is a criteria of antipsychotic or antidepressant, right? It takes 2 weeks to work, isn't it? Because it takes time to have the genetic expression actually. So gradually you will taper the dose, and you gradually will increase the dose of the another one. So failed medication is generally tapered by the same amount of each dose decreased. Okay, so it's not like same venlafaxine, same mitrazepine you will use. It's not like that. So if you're using another one, it should be a balance. I hope you got the point. Actually, we'll go with the conception. So not directly like blindly we'll go, okay, this one's answer is this. Okay, I hope you got some points, and you will see more recalls in future regarding this. Actually, it's a very high yield concept, that one. So the answer of the question, this one is B actually. B is the answer. Okay, next question. I'll ask Dr. Is Dr. Faith is here, or?
Yeah, I'm around.
Okay, great, doctor. Can you read this question for me, doctor?
57-year-old Caucasian man presents with a complaint of feeling overwhelmed with life. He has felt depressed for the past 6 months and states that he has difficulty focusing on daily activities. His sleep is poor, wakes up frequently at night. Further inquiry reveals that he's a Vietnam War veteran and he experiences flashbacks and nightmare about his combat experiences. He notes that the flashbacks began prior to his feelings of depression. He avoids watching war movies and refuses to discuss with anyone about his time spent in Vietnam. This is his first visit to a psychiatrist and he asks to be started on some medication. Which one of the following should be avoided in this patient? Lorazepam, nortriptyline, paroxetine, exposure therapy, cognitive therapy.
Okay, thank you, doctor. So, any ideas? Feeling overwhelmed by life. Then there was like flashback, something written,
Post-traumatic stress
nightmare.
disorder.
Yeah. So it is traumatic stress disorder. Okay. According to John Murtagh, we can divide the post-traumatic stress disorder into two types. Like it is acute and it is chronic. There's another one, stress disorder. How to differentiate? First of all, PTSD with stress disorder. Any idea? First of all, how to differentiate between these two?
In PTSD, there is a history of like past trauma and
Let me tell you, in both cases there could be past trauma. Okay, like someone close died, this kind of thing can happen with any of them, because the how the human as like as a human, you like someone will respond. It's up to it varies with different person. So the differentiating point is stress disorder will look for, it should be less than 1 month. It should be less than 1 month. Okay, and in case of post-traumatic stress disorder, it should be more than 1 month. Again, this post-traumatic stress disorder we can differentiate into acute, and chronic. So how can we differentiate acute and chronic? In acute, it should be more than 1 month, but less than
3 months.
less than 3 months. Okay, and in chronic, we understand it should be more than 3 months. Okay, so that is important for us. Okay, so if you can remember, so how to differentiate, like always I say the time and those things are important. In case here they are not asking like stress on or PTSD, but sometimes they will give you to differentiate between like what is your proper diagnosis. So just remember this timeline, it will be helpful for you. So now come into this question. There was flashback, there was nightmares for a while, like it's a lot of time, past 6 months. So diagnosis is among these three: stress, acute PTSD, chronic PTSD. So what do you think? I think this one, right? Chronic PTSD, I think it's a more correct diagnosis. So if it's a chronic PTSD, what you should do? Interesting one. Which one of the following should be avoided in this patient? Initially maybe you are very happy, oh wow, I diagnosed the case, but suddenly when you saw the last time, which one of the following should be avoided in this patient? Any problem with therapies? Let's try to explore. Any problem with therapies?
No,
I don't think
therapy
so.
should be.
Yeah, and I think exposure therapy is not really applicable in that way, because like someone is afraid of snake or phobia, then that exposure therapy is applicable. Okay, so this is even not applicable in this case, exposure therapy, but cognitive behavioral therapy of course you can give. So E is okay here, I think. So we should not think of this D and E. Let's come to these three, like which one we should choose. Any ideas now? Okay, let me tell you the answer. Actually, the answer is actually lorazepam. Now can you explain why lorazepam?
Long-acting benzodiazepine.
No, that's a non-acting benzodiazepine, but what is the harmful side of using benzodiazepine for long time? I already gave you a hint here. It's a chronic case.
Dependency?
Dependency. Yeah, so it's very clearly written. If you can see in PTSD and that one, even it's written, I think in John Murtagh, also in Kaplan. Also, I've seen a question bank, like it was also written there that you should not use benzodiazepine for longer time actually. So that's why the lorazepam is you should avoid when it comes with the chronic one. So chronic one, because he will like it, when he will take it, he'll sleep well, he will start using that one. So like he will get some addictive or some dependency in this case. So we should avoid the lorazepam. So A is the answer here. Okay, so see, A is the answer here, the one that should be avoided. Okay, like so diagnostic criteria are made, flashback, nightmare, these things are made actually, and symptoms might be present longer because the does not strongly associated with substance abuse and other things. Benzodiazepine should be avoided when possible. So therefore lorazepam should not be used in this patient. So that's why A is correct here. Okay, next one, interesting one. This one I'm reading, like mother brings her 7 months old child with complaints of bleeding from mouth and gums, and there was some torn frenulum. Okay, she told that he bumped his head somewhere, so that he presented like this. On examination, the child, I think the child has oil bruises on the shin and the forehead, and no hepatosplenomegaly, no petechial rash. So by saying no petechial rash, what they're trying to exclude actually?
Any
No.
bleeding disorder.
Okay, bleeding disorder. We can also say
It is.
HSP, henoch-Schönlein purpura. Some of the lot of the bleeding disorder which are associated with non-blanching rash. Also, if you add anyhow that meningococcemia, also non-blanching rash. So a lot of things are associated with petechial rash. Basically, the word is very nice. The bleeding disorder. Okay. Any idea what it could be?
B.
Child abuse.
Yeah, it's more likely. Okay, actually the answer is B. So now can you tell me why the answer is B? Now can you tell me why the answer is B?
There is old bruises
Yeah,
on
all
chin and
this.
forehead.
All this. Lots of sounds are coming. I think sound.
Moreover, the boy is only 7 months old.
Yeah, 7 months old and torn frenulum. How come his 7 months just son, like he would put his head and he'll torn his frenulum. So like his statements and other things, this is not matched actually. Okay, so that's why this is child abuse. Now another question. Also, please, yes.
Also for factor 8 and factor 9 is hemophilia.
Yes.
And hemophilia would present with much more of hematorosis and
Yes, those bleeding points, right? Some of the bleeding points and other things. And I have seen in many cases, like when there is a bleeding disorder is given, usually they try to give some labs, like less lab bleeding, like bleeding time, clotting time, nothing is mentioned. So sometimes we just have to be little smart on this. So nothing is mentioned, or maybe the recaller has forget, like I'm telling you, like it is very common, like giving the labs in AMC exam. Not only in AMC exam, in every exam they give labs. They give the drug. These things are common. Okay, now let me try to